Welcome to Montgomery Heart Wellness. We have an interesting show for you tonight. We're going to talk about fainting. And we've had a number of questions in the comment section about fainting. And of course, we see a lot of patients who come to our clinic with the symptoms of fainting. And so it's a very important topic. And the question we pose is fainting, is it benign or serious? And my talk today is going to answer just that question. I'm going to get into the details of why fainting could be benign or why it might be serious. So let's just look at the whole concept of fainting. And we always like to start off with a definition. So the definition, the medical definition of fainting is we use the medical term syncope. Now, that's a term that essentially means the transient loss of consciousness. So transient means you lose consciousness and you come back spontaneously. It's typically rapid onset. Sometimes it can have a warning syndrome. It's typically brief. And there's a spontaneous recovery, which is an important characteristic of it. Now, there's some other conditions where one can lose consciousness or become unconscious, if you will, but they don't quite meet the criteria for syncope. So hypoglycemia is one. It can cause consciousness or loss of consciousness, but it usually is in the form of a coma. And this is a medical emergency. There's no spontaneous recovery. If someone's unconscious due to hypoglycemia, you have to give them glucose. Oftentimes it's a mental stupor that can precede it. So someone's blood sugar is very low. They might not lose consciousness, but they may have a mental stupor, may not be sort of with it, if you will. Stroke is another condition where you can lose consciousness, but most of the time a stroke presents with neurological deficits. So a drooping face or inability to speak or numbness or tingling, and sometimes dizziness, depending on where the stroke occurs in the brain. If the stroke is severe enough to cause loss of consciousness, again, similar to hypoglycemia, it's usually in a setting where the person's in a coma. How about seizures? Now, seizures typically have jerking-like movements. We refer to them as tonic-clonic activity. The seizure episode is more prolonged in duration. And these are the typical grand mal seizures. Now, people can have what's called atypical seizures, where they have staring spells. We call them petit mals or the like. But individuals with fainting spells and tonic-clonic activity, they may not necessarily be having a seizure. So someone who has hypoglycemia due to one of the common causes of syncope, if the blood pressure drops suddenly and you don't lay the patient down, they may have some jerking movement in a similar way that a person with a seizure may have. So, but I've seen oftentimes people get diagnosed with a seizure where it's oftentimes a vagal spell. So let's get into the common causes of fainting. And fortunately, I'll just say up front, the most common causes of fainting are essentially neurocardiogenic. Now, I'm going to go through this in a mean. It's an abnormal reflex between the central nervous system and the cardiovascular system. The differential diagnosis can be a reflex. We call it vasovagal. Sometimes cough or sneezing or going to the bathroom at night, defecation, these things can cause the vasovagal spell. Orthostatic, if you're volume depleted, or certain medications can cause the blood pressure to drop due to orthostasis. Now, volume depletion medication and other neurological conditions that can cause an abnormal reflex. And we'll talk about some very common causes of orthostasis. And then cardiogenic, slow heart rate, we call it bradyarrhythmias, tachycardias, fast heart rate, usually from the lower chamber, or mechanical structural abnormalities to the heart can cause it. And then, again, these are things that syncope mimics, as I said before, seizures, cerebrovascular, syncope, alcohol, blackout, sedation, psychogenic, pseudosyncope. Some people who are in a psychogenic state will fake passing out. But the cardiogenic ones we're going to spend some time on later. they can be the more problematic. Here's another breakdown: neuroendocrine, orthostatic, cardiac arrhythmias, and structural cardiomyopathy, cardiopulmonary diseases. These tend to be ones that are more life-threatening, and we're going to talk about these later on. But fortunately, as you can see, the majority of the causes of fainting, neuroendocrine, are the benign causes. So if you combine this plus this, 75% of the time when someone passes out, that's a benign cause. So that's good news to know offhand. So what's this neurogenic mechanism? Neuro means brain or central nervous system. Cardiogenic is the cardiovascular system. So there's an interplay or balance between the central nervous system and the cardiovascular system. And so neurogenic fainting is an abnormal reflex between the central nervous system and the cardiovascular system. There's a sympathetic component and a vagal component. The sympathetic's your fight or flight. The vagal slows things down. Sympathetic increases heart rate, increases blood vessel tone. The vagal decreases heart rate. So there's certain things that can trigger an imbalance between these two. And so when you get an imbalance, when these things are keeping each other in balance, everything's fine. If you get an imbalance, sympathetic withdrawal or vagal increase, you can cause a drop in heart rate and or blood pressure, which would then cause a person to lose consciousness. There are two basic types we call predominantly vagal. That's an increase in vagal tone. That's the heart rate slows down rapidly. There's a vasodepressor. That's mostly due to the sympathetic nervous system that's withdrawing, so the blood vessels dilate. And then oftentimes there's a mixture of the two, which is what you see probably most of the time. Now, this is a complex diagram. I show it to you largely to just give you a feel for the complexity of the body, how it works, the complexity of how blood pressure is maintained. And if this delicate balance is off, then you can lose heart rate and lose blood pressure and therefore lose consciousness. So there's certain receptors, in certain parts of the body. The sinus node, it controls the heart rate, vagal outputs, and you have sympathetic inputs. And so if you decrease the heart rate too much, then that leads to vagal component, blood vessels, vascular tone. If the blood vessels dilate, then the blood pressure drops rapidly. So again, complex slide, but the purpose here is to give you some level of understanding of the complexity of this syndrome, not so much to bog you down into the details. Now, you have the brainstem, which is part of the central nervous system. It gives feeding to what we call the sympathetic withdrawal or increased vagal tone. If the vagal tone increases, bradycardia, or slow heart rate ensues, so that can cause you to pass out. If the sympathetic nervous system withdraws, the blood vessels dilate and the blood pressure drops, and that can cause syncope. These are the basic two pathways that you have in neurocardiogenic syncope, and they're mixed. Now, there are some special episodes I want to talk about. Postural orthostatic tachycardia syndrome, POTS. Many of you, we have a number of patients coming in with POTS, and lately we've been seeing an increase in POTS. Essentially, what POTS is pretty much a pure vasodepressor. So you're having a withdrawal of the sympathetic nervous system, the blood vessels dilate. And so when somebody goes from sitting to standing, the tank empties and less blood flow to the brain, and therefore the person pass out. Here's a more complex picture. Here's a person getting a vital sign, blood pressure sitting 129/73, heart rate 70. When she stands up, blood pressure goes up and the heart rate goes up. Now, sometimes the blood pressure may not go up enough, and it may not go up at all, and the heart rate may go up. So this is the normal process where you have increased sympathetic tone, but if the blood pressure doesn't go up, she can have dizziness, lightheadedness, shaking, and sweating, and the like, and you can get vasodilatation. Sometimes we see an initial increase in blood pressure with a subsequent rapid drop in blood pressure after they've stood up. And so you have ways we can diagnose it. We can diagnose by a simple test where you sit and stand. We can do a tilt table test, which we do oftentimes. It's more closely monitored, monitor EKG and the like. And we're looking at how these different mechanisms work. So in terms of making a diagnosis, someone comes in, they have syncope, you always want to take a history, do a physical exam. And most of the time, you're going to really pick it up here. Most of the times I pick up and can make a reasonable um, um, diagnosis with the history of the physical. And then you do tests to confirm what you suspect. Syncope, orthostatic hypotension, reflex mediated syncope, cardiac unknown cause, non-syncope. The patient says, well, I pass out. When you talk to them, they say, no, they tripped and fell. So you can easily disclaim that. The risk stratification is very important. Someone who's at low risk, it's an isolated event. They're young, they're healthy. Intermediate risk, they may have a questionably abnormal EKG. High risk is somebody who's older and EKG is abnormal, and you may want to do more workup on that person. So looking at the differential diagnosis, you have the initial syncopal episode. If the diagnosis is uncertain, if you're certain or high likely diagnosis, start treatment. And as I said, most of the times we can pick this up on history and physical. If it's a question mark, you're going to do some other tests. Like if it's a 55, 60-year-old person, they come in, they have a gash on their forehead, and say, I passed out the other day, I'm going to be suspicious of a cardiac cause. And so I'm going to do a much more detailed cardiac evaluation. If the cardiac is unlikely, then you may do ECG monitoring, tilt table tests, or something like that. If cardiac unlikely with rare episodes, you may not do much else after that. Low risk people tend to be young, single episode, tend to be provoked, no EKG abnormalities, no history of heart disease, no family history of sudden cardiac death. So dangerous versus benign. As I said, benign people are usually younger, no personal history of heart disease, no family history of cardiac arrest, and no chronic illnesses. Potentially more dangerous. Now, these are broad guidelines, okay? And sometimes people are fit into them, and sometimes it's mixed. But older than 45 years of age, a history of cardiac disease, a history of other chronic illnesses, a family history of cardiac arrest, or a personal history of frequent episodes of passing out. So what are the common treatments for syncope? First of all, you want to look at the medication they're taking, because like alpha blockers, men that take medications for BPH will have syncope related to that, and certain blood pressure medications. Any blood pressure medication can contribute to syncope. So you want to look and see what the patient's taking and be mindful of that. The non-cardiac removal of potentially causal agents, hydration and sea salt. Okay, so if there's neurocardiogenic, if it's an alpha blocking drug, etc., you remove it first, see how the patient does. If they still have syncope, then you may use hydration and sea salt. There's special medications that we can use. Metadrin is one, and there are others. Now, cardiac syncope. You think the person's having syncope due to cardiac ischemia or heart attack. So if someone passes out and they go to the emergency room, they've had a heart attack, of course, that's going to be treated like a heart attack, a primary electrical disorder. If they pass out and the heart rate is very slow, they'll be treated for the slow heart rate. Or if they have a ventricular arrhythmia, they'll be treated for that. And then primary structural diseases like aortic stenosis and the like. So the cardiac causes require more in-depth evaluation, and so it's more serious than the other causes of syncope. So what are some important practical tips? What to do if you witness a fainting spell? And I tell my staff this all the time: lay the person flat on the back immediately, and then evaluate their level of consciousness after, and then call for help. Always lay them down. So when should you call for 911? For any older person who loses consciousness, anyone who does not regain consciousness immediately after being laid flat, and for anyone in which there's a doubt of the level of consciousness. Other practical tips: when should you have more cardiac testing? And this goes for individuals who are diagnosed with fainting by their doctors. For seemingly benign cause, it continues to recur for treatment, or if you're older than 45 years old. And should you have an AED at home? Now, this is a great question. And I really came up with this recently because I've had some patients who've had family members suffer cardiac arrest at home. And I think in this day and age, we probably should lean more toward having an AED at home. The answer is yes. It's practically important if someone in the house has increased risk for cardiac arrest or fainting. An AED, the AED company. Now, here's a shameless reference. Avive.life is a company. Now, a disclaimer: I invest in this company, but if you go to the website, this is a very user-friendly AED. When you activate it, it's very easy to hook up. Plus, the AED itself, it can dial 911. Plus, it can locate other healthcare practitioners in the area who may also be Vive users. So it has a lot of practical benefits in terms of being easy to use. So, but the key is to optimize your health as usual. Optimize your health and stay conscious. That's always the key. And that's always something mindful of because, optimizing your health gets to the core of all of these things. So I hope that was helpful to you. Fainting is something that, we see a lot of. It's important for you to understand the difference between a potentially dangerous cause or an underlying dangerous cause or a benign cause. So I hope that was helpful. And of course, if you're new to the channel, please subscribe. If, of course, you're one of our regulars, please share. There's important information with other people. Until next time, take care.